Hello, my name is Peter Grayson. I'm going to talk to you today about how I treat Vexas syndrome. The easiest way to explain this is to start by telling you about a case of Vexas, and this is actually the first patient I ever saw with Vexas, whom I saw at a time before we even knew what this disease was. So this was a man in his late 50s who in 2011 presented to his doctors with an unusual combination of clinical features, which included fever, orchitis, skin nodules, face swelling, deep vein thrombosis, and chondritis of his ear. His local doctors had a difficult time managing his disease, and they had tried many different therapies. The only thing that consistently worked for him was glucocorticoids. And they had tried many different sparing therapies, including conventional DMARDs like mycophenolate mofetil, methotrexate, and azathioprine, without much success. And they even gave him cytotoxic therapy, which was cyclophosphamide, but this was only mildly temporizing at best. He still needed daily doses of glucocorticoids to keep his inflammation symptoms controlled. And he was referred to the National Institutes of Health, where I work, in 2013, and seen by our undiagnosed disease program, which is a program where we see cases that are difficult to diagnose or classify. And when we saw him, he told us something rather remarkable. He said, "I'm taking 25 milligrams of prednisone a day, and I'm doing pretty well. But if you reduce my dose, even just by a little bit, my disease will come back quickly." And so we had him in the hospital under clinical observation, and we did that experiment. We dropped his steroid dose only to 20 milligrams of prednisone a day, so a minor decrease. And within 24 hours, his symptoms came back. And we were able to observe that periorbital swelling of his face that he was telling us about, which is shown here in this picture. And we watched his acute phase reactants increase very quickly and dramatically. His C-reactive protein was 30 milligrams per liter at presentation and went to over 300 milligrams per liter in just a matter of 3 days. And he began to have recurrence of those painful skin nodules, which we biopsied and saw that they were medium vessel vasculitis of skin. And we thought at the time, since Vexas was not yet discovered, that he had an unusual form of polyarteritis nodosa. And we helped his local doctors try to manage his disease. We tried biologic therapy. When he was given anakinra, which is an IL-1 inhibitor, he developed a very severe injection site reaction, which is shown here. And he started to develop progressive bone marrow failure, which began as a macrocytic anemia and then thrombocytopenia. And his daily glucocorticoid dose requirements continued to escalate. In 2017, he underwent a bone marrow biopsy because at that time he had worsening anemia and he was requiring blood transfusions. And his biopsy was non-diagnostic. It showed hypercellular marrow with myeloid predominance, and he had negative cytogenetic and genomic studies for myelodysplastic syndrome. And we still just didn't know what his diagnosis was. He continued to be managed with immunosuppressive therapy, and he continued to get worse, starting to develop fevers and inflammatory infiltrates in his lung, and then he developed a disseminated mycobacterial infection. In addition to blood transfusions, he now required platelet transfusions, and he was hospitalized many times for infectious and inflammatory complications of his illness. And unfortunately, in early 2020, he died from complications of his disease. We now know that this case is very classic and very typical for this newly discovered disease known as Vexas syndrome. And what this case really highlights in the context of treatment is this fundamental principle that at the present time, treatment of Vexas is very challenging. And this patient had very typical features of that display the type of challenges a physician will encounter when they try to treat this disease. One is that we tried many different steroid-sparing therapies, and we had modest success at best. The only thing that helped his disease were steroids. And the second really key principle here is how sensitive his disease was to glucocorticoids. If we reduced his prednisone dose even slightly, his disease would come back very dramatically. But if we maintained him at a consistent dose of steroids that was high enough to treat his inflammation, he did pretty well. And when you think about treating this disease, the main principle that you need to understand is what is the mechanism of disease, because that informs your treatment decisions. And we know that this is a disease of a mutation in bone marrow that's acquired sometime later in life. And I'm showing you pictures here of chromatograms, and this is basically sequencing of the UBA1 gene at codon 41, where mutations frequently occur that cause the disease. And in these chromatograms, these patients have normal cells that don't have the mutation, which is the red peak, the wild type peak. And then they have other populations of cells which do carry the mutation that defines Vexas in the blue peak. And if you look at the level of the stem cells in bone marrow, there's equal blue and red peaks, meaning that many of these cells have this mutation while others don't. And when you look through maturing blood cells to neutrophils and monocytes in peripheral blood, you can see that they're almost all blue peak, no red, which means that the majority of this patient's myeloid cells, their neutrophils, their monocytes, have this mutation. In contrast, if you look through the lymphoid cell lines to mature T cells and B cells in circulation, you can see they're all red peak, no blue, meaning that the lymphocytes in this patient do not carry the mutation. And it's that fundamental understanding that really informs treatment. So this is put another way. We can measure the amount of cells that have this mutation in a metric known as the variant allele fraction. And we can see this is a mutation that's only in the blood, so skin fibroblasts do not have this mutation. And it's only in myeloid populations, so T cells and B cells in circulation do not have the mutation. But if you look in these myeloid populations, sometimes 80 to 90% of the cells carry this mutation. So the medications that we would use to treat this are really going to target inflammation that's produced by myeloid cells, rather than targeting the lymphocyte population. And the other thing to understand is the natural history of Vexas. And there's a lot of differences from one patient to the next. But the classic Vexas patient, like the patient I told you about in the beginning, starts out with inflammation symptoms, often inflammation in the skin, and then develops progressive bone marrow failure, which usually starts as macrocytic anemia, and they can become transfusion dependent, and thrombocytopenia. And this is an example of a patient who's had worsening anemia, worsening platelet counts in the red and orange lines, and eventually evolves into being diagnosed with the myelodysplastic syndrome. So as we're treating this disease, we're treating the inflammation component, and we're trying to affect and prevent progression of bone marrow failure. This is a wonderful review by our French colleagues, which really highlight the principles of treatment in Vexas. In putting it into three main categories. One is targeting the clone. Can we use medical therapies to eliminate the blood cells that carry the mutation? Another way is to block the inflammation pathways, the inflammation response that is a consequence of the mutation. And as I mentioned, this would focus more on myeloid-directed therapies, so cytokines that cause inflammation that are produced by monocytes and by neutrophils. And these generally include IL-1, IL-6, and TNF. And then supportive care. And there's a lot of complications related to the disease, and I'll go into those in a little more detail. So the goals of medical therapy are to control inflammation. And as I mentioned, glucocorticoids are really essential here. The only medication that effectively works to control inflammation in most patients are steroids. And the principle here is patients require a lot of steroids often, and when you're reducing steroids, you need to do it very slowly and carefully. Many patients have an individualized steroid dose that they need to take every day to keep their disease under control, and if you go below that, their disease comes back. So you need to try to identify what's the least amount of steroids the patient can be on that's still effective. And often we can't get patients below 10 milligrams of prednisone a day or the equivalent. And most patients never completely come off of steroids. And this speaks to the fact that we don't have great steroid-sparing therapies yet for the disease. But the preferential choices would be medications that target myeloid cells, including IL-6 antagonists like tocilizumab, JAK inhibitors, and IL-1 antagonists like anakinra or canakinumab. With any of these medications, we have to watch out for medication reactions. Very often, the cytopenia can worsen in response to many of these medications, and infectious risk from immunosuppression with these medications. And it's also important to note that IL-6 antagonists or JAK inhibitors may be effective to treat a patient's symptoms, without having a dramatic steroid-sparing effect. So sometimes patients feel better, their disease flares are less frequent and less severe on these medications, even though they're still unable to reduce their prednisone dose significantly. But the main message here is that we need randomized controlled trials to prospectively determine which drugs are the best and which ones to use preferentially. And as it stands, which medications people use first is really dependent on their practice. Another thing to understand is that the lymphocytes in Vexas are affected by the disease. And I mentioned to you that the T cells and the B cells in the blood don't carry the mutation. However, the mutation is really toxic to lymphocytes. So as a lymphocyte is maturing in the bone marrow, if it has the mutation, it doesn't survive to full maturation, which is why the B cells and T cells in blood don't carry the mutation, because the ones that do have died during maturation. And understanding that, and understanding that a patient will have low CD4 T cells, low CD8 T cells, low B cells is important, because therapies that target lymphocytes will make these patients worse. If you give a patient a B-cell depleting therapy like rituximab, it will eliminate what little B cells they have, and it's not effective. So that's a medication that we avoid. And even though I said the mutation isn't in T cells, the T cells are seeing those dying neutrophils and monocytes, and it can secondarily activate them. And that's what the flow cytometry graph is showing on the right, is basically patients with Vexas have activated lymphocytes in response to the dying neutrophils. So sometimes use of conventional DMARD therapies like methotrexate can have additive benefit to try to treat off-target effects of the disease. A fundamental goal of medical therapy would be to get rid of the clone, to eliminate this mutation. And the most promising agents in this regard to date are hypomethylating agents, specifically azacitidine. They're typically given to patients whose marrow disease has evolved into meeting criteria for myelodysplastic syndrome, and perhaps that's too late. There have been some case reports of this medications being given earlier in disease where we've reduced or eliminated the mutant burden of the disease in both the blood and their marrow. And so we need clinical trials to figure out, are hypomethylating agents a preferred agent because they have potentially the ability to eliminate the mutation, and when in a course of disease should we think about this option for patients. And that speaks to the idea that in the future with Vexas, I think medications that directly affect UBA1, which is the gene that's mutated, are likely to be the most effective therapies, are likely to be therapies that may lead towards medical cures, but this is still to be defined. We do, however, have one curative therapy, which is allogenic hematopoietic stem cell transplantation. And so making a decision of whether or not to offer bone marrow transplantation to a Vexas patient is complicated because these are older patients, often with comorbidities. So we need to choose patients that are healthy enough to undergo bone marrow transplantation because the procedure is risky and carries a lot of potential complications. However, patients that are successfully transplanted are fundamentally cured of their disease. And one way we're starting to identify this is understanding that patients with Vexas have different mutations in the UBA1 gene, and depending on the mutation, it determines how severe their disease is and what their risk for death is. There are three main mutations at codon 41 and methionine, at codon 41, where a methionine amino acid becomes either a leucine, a valine, or a threonine. And these are survival curves from the NIH cohort showing that if you have the valine variant in red, that you're at highest risk for death. And no patient with this variant in our cohort has survived longer than 12 years from symptom onset. And so it's quite possible in the future that patients who possess these more high-risk variants will likely need more aggressive therapies earlier, but that remains to be determined. Thromboembolic disease is very common in Vexas. Approximately 50% of patients will have a blood clot, and they can be venous or arterial, and they happen often at the time of diagnosis, but can happen anytime throughout the disease. They are likely related to uncontrolled inflammation, and they can occur even in patients who are taking oral anticoagulant therapy. We do not yet know what the best regimen is to prevent clots in these patients, but we do know that prophylaxis is recommended in high-risk settings, such as hospitalization where a patient could be immobilized. And after the first thrombotic event, we often recommend lifelong anticoagulation. So this is a very important part in the management of these patients. Another important part is the fact that they get a lot of severe and often atypical or opportunistic infections. And these are survival curves from the NIH showing that these patients can get non-tuberculosis mycobacterial infections, and they can get pneumocystis infections in the lung. And when they do, it dramatically affects their survival. So here we can see patients with mycobacterial infections whose survival curve compared to the remainder of Vexas patients is dramatically affected. And the same goes for pneumocystis pneumonia. And this is a patient of ours in our cohort who has 2 different mycobacterial infections in skin. And the point being here that we need to have an index of suspicion for these types of infections, and we need to potentially make this diagnosis and institute antibiotic therapy. But similarly, it's likely that these patients do need some form of prophylaxis. So we recommend strongly that every patient with Vexas be considered for prophylaxis, particularly for PJP and for alpha herpes viruses, which often reactivate in the course of the disease. So in conclusion, Vexas is caused by somatic mutations in bone marrow that are reflected into myeloid cells in peripheral blood, and steroids are essential for treatment. You need to be very careful with how you use steroids in these patients, tapering slowly, identifying the lowest dose that controls their symptoms, and trying to then minimize all the complications that are inherent to long-term use of glucocorticoids. Steroid therapies that target myeloid-driven inflammation are preferred, and so tocilizumab and JAK inhibitors are often the first-line therapies. And we clearly need new therapies in this disease, and hopefully in the future, medical therapies that actually target these mutant clones and eliminate them may lead us towards cure. And thank you very much for your attention.